Welcome to Monitoring Acute GVHD with Biomarkers, How to Interpret Changes in the Map, powered by Eurofins Viracor webinars, presented by Dr. James Ferrara.
Thanks very much for the introduction. I'd like to talk to you today about monitoring acute GVHD with biomarkers, and specifically how to interpret changes in the magic algorithm probability, or MAP. So to understand the biomarkers in the MAP, I want to spend just a little time explaining the biology of what's going on here. So we think of these biomarkers as a kind of liquid biopsy. And during GVHD, the biomarkers, these two biomarkers, ST2, which is the soluble IL-33 receptor, and regenerative 3 alpha, or reg3 alpha, which is an antimicrobial peptide. Both of these proteins serve as a kind of liquid biopsy of the damage that occurs in the GI crypt. Because reg3 alpha is stored in Paneth cell granules, when the crypts are damaged, the Paneth cells spill their intracellular contents into the systemic circulation. And ST2 is released from a variety of damaged cell types, including endothelial cells and mesenchymal cells, and even activated lymphocytes themselves. So these biomarkers provide data that illuminate new GVHD targets in the crypt, and they suggest novel approaches to prevent and treat GVHD. And in particular, they allow us to monitor how well those treatments are working. So a little biology, you can see here that there's this paradox that when the reg3 alpha goes up in the serum, it actually goes down in the GI tract. And so you can see on the bottom here, these are mouse data where the amount of reg3 alpha in the serum goes up about 50-fold during graft versus host disease, whereas the mRNA expression for reg3 in the intestine actually goes down about 10-fold. And this is also true in humans. Here we see data from about 30 patients where the serum levels of reg3 increase, in this case, about 10-fold. This was at the onset of graft versus host disease. Whereas when we looked at immunohistochemistry in a semi-quantitative way for reg3 staining, the protein expression decreased by at least 2-fold. So what we see in the mouse is not an artifact of what happens in humans. Now, these biomarkers are released from throughout the GI tract, and they are especially sensitive to changes in the distal small intestine, or ileum. But these biomarkers can work even when there are no symptoms of graft versus host disease that have yet occurred, because the damage first occurs in the crypts. So these are data that we published about 3 years ago in JCI Insight, where we looked at 7 days after transplant, before anybody had any symptoms of graft versus host disease. And what you see here on the left is non-relapse mortality, with an overall incidence of 13% at 6 months. And when we use the biomarkers to divide them into high-risk groups and low-risk groups, what you could see is that there was at least a 2-fold difference in the mortality in the high-risk group, which represented about 20% of the patients. And in the low-risk group, which was 80% of the patients, it was still only about 10% non-relapse mortality. And because this is not related to relapse, you see the overall relapse-free survival is also highly significantly different in these two groups of patients that are distinguished just on the basis of the MAP. And this was about 358 patients from the MAGIC consortium. These differences in outcomes are true for each important subgroup. So here we're showing you related donor transplants, where you can again see 87% of the patients were low risk and had less than 10% mortality, whereas 13% of the patients were high risk and had almost 30% mortality. And then in the unrelated donors, the overall pattern was very similar, with low risk versus high risk, about a 2.5-fold difference. But what was important here is that because unrelated donors are more likely to have graft versus host disease and a non-relapse mortality, what you see is that the proportion of unrelated donors that were high risk by biomarkers increased from 13% in the related donor group to 23% in the unrelated donor group. And we saw essentially identical results when we looked for HLA mismatch and conditioning intensity. The patterns of non-relapse mortality remain the same for the high-risk group being 2.5 to 3 times higher than the low-risk group, and it was just the proportion of patients that would be different in each of those subgroups, like HLA mismatch. What we also found was that even at day 7 after transplant, we could predict who was going to get a severe graft versus host disease, particularly GI GVHD, and it is GI GVHD that drives the non-relapse mortality. So in the low-risk group, there was only 8% stage 3 and 4 GI GVHD, where in the high-risk group, it was twice as high at 17%. Again, a highly statistically significant difference. And the GVHD mortality in the end was 34% in the low-risk group versus 59% in the high-risk group. Again, a highly significant difference between these two groups. So let's look at a case. So this is a clinical case of a 43-year-old male who has FLT3 positive AML in first remission. He receives an unrelated donor bone marrow transplant. He receives flu-Buf4 conditioning, and he gets TAC methotrexate as GVHD prophylaxis. Now, his early post-transplant course is uneventful, and then on day 12, he's febrile twice to 102.8 degrees. And actually, it was 3 times. The third time was even higher, is 103.1. Now, it's day 12. He has no rash. He has no diarrhea, and his bilirubin is 1.6. So he doesn't have any clinical GVHD by the standard grading. Is this engraftment syndrome, or is this going to turn into high-risk GVHD in a couple of days? And if you do biomarkers on this patient, what we found was that his ST2 was actually pretty low at 26,000 picograms per ml, and his reg3 was essentially at the lower limit of detection at 8 nanograms per ml. So the p-hat, which is the old term for the MAP, that was 0.072. That was low risk. And if you were to get your biomarker results from Viracor, this is the way it would look. You'll see up here, it says acute GVHD pre-symptomatic algorithm. That's what you would put on the requisition slip. And you would see here that I've highlighted that it's less than or equal to 0.16. That equals low risk of severe acute graft versus host disease in NRM. And you can see the biomarker levels submitted here. So this is the first case where our patient would be on the blue line here, low risk, even though he's got this febrile, very febrile. He's not had any damage yet to his GI tract. So he remains low risk, and there would be a brief symptomatic intervention. You would not start additional immunosuppression on this patient. given these biomarkers. Okay, well, what about at the onset of acute graft versus host disease? I'll show you now some data from about 250 patients that are part of the Mount Sinai Acute GVHD International Consortium, or MAGIC. And we look at biomarkers on our patients that are receiving best available therapy. And in this case, that would have been systemic steroids. So we've got these 250 patients. They all have a clinical grade 2, and the vast majority have just skin disease. And what we found was that if you look at the biomarkers and determine the maps, the low risk group has a 6-month NRM of only 8%, 12-month NRM of only 12-month NRM of only 8%. The intermediate group in gray has a 12-month NRM of 22%. And the high-risk group has a 12-month NRM of 46%. So this is exactly the same as our published data. And what you can see here is that the Ann Arbor 1 goes from 0.001 to 0.14. Ann Arbor 2 goes from 0.141 to 0.290. And Ann Arbor 3 goes from 0.291 to 0.999. So that's the non-relapse mortality. The resistance to steroids is very low in the Ann Arbor 1 group, so that's about 20%, and it increases stepwise so that in the Ann Arbor 3 group, it's over 50% who are resistant to steroid treatment. And what you can see here is that over 60% of the patients are actually the low risk group, Ann Arbor 1. About a quarter are Ann Arbor 2, and 15% are Ann Arbor 3. So for this group of patients, the low risk, the 61% low risk, they could either use low dose steroids or maybe even a non-steroid treatment, whereas the intermediate and high risk group should have something in addition to steroids because their mortality and a risk of severe GVHD is much higher. I'm just going to show you some data that these results are also true for pediatric patients. So we've now looked at over 100 pediatric patients from the MAGIC consortium. And if you look at the, this is a receiver operating characteristic curve. In black, you have the clinical GVHD, and in blue, you have the map. This is at the onset of treatment. And the more that this curve looks like a right angle, the more accurate the test. So this is sensitivity, or the true positive rate, on the y-axis. And it's actually the false positive rate, or 1 minus the specificity, on the x-axis. So you can see here at this flexion point, we've got about a 90% sensitivity and about a 70% specificity, because remember, false positive is 1 minus the specificity. So this shows how highly accurate the map is at the onset of GVHD. And for less than 21 years old, you can see the cumulative incidences of NRM, which are very similar to what I just showed you for the overall group. That was in 194 patients. And we had almost 100 patients who were less than 12. And you can see that the relative incidences of non-cumulative incidences of NRM are also significantly different between the Ann Arbor 1, 2, and 3 groups. And just to show you that this is also true after treatment. So these are responding patients where you can measure the maps and you can still see that there is a high risk, much higher risk of mortality if the biomarker levels stay high and the MAP remains above 0.29. And in the non-responders, that's even more dramatic, with the mortality rate in the non-responder pediatric patients who are greater than 0.29 of approximately 75% by 6 months. So what is true in the adult patients is also clearly true in pediatric patients. So let's go back to our case. This, of course, is an adult patient. He's 43 years old. He engrafted on day 13. He responded very well just to some antipyretics. He was discharged on day 20. But he comes back 9 days later, and he's got an itchy rash that's about that looks like GVHD. It covers about 60% of his body surface. He's had 3 episodes of diarrhea, so that's stage 1 GI, and his bilirubin is 1.9 milligrams per deciliter, so that's stage 0 liver. So overall, he's acute GVHD grade 2. So if we send biomarker results now, what we see is that his ST2 is higher, but his reg3 is still very low at only 8 nanograms per ml. So his MAP is 0.119. That's definitely an Ann Arbor 1. And this is what the biomarker results would look like for this patient, because you now see it's the acute GVHD symptomatic onset algorithm, where they give you the numbers for the high risk, the intermediate risk, and the low risk. And he is less than, he has this result of 0.119. So you interpret it as being less than 0.14 or low risk for severe acute GVHD in the future and NRM. So he again is on the blue line. He'll only have about a 10% non-relapse mortality 12 months after the diagnosis. He's only got a 1 in 5 chance of being resistant to steroids. So the approach for him would be less immunosuppression. And in this case at Mount Sinai, we had a phase 2 clinical trial of non-steroid treatment, or the JAK1 inhibitor, itacitinib. So the same patient, same clinical presentation on the day 29 visit. He's got overall grade 2, but you send the biomarkers, and now you get a different result. I've left the ST2 the same, but now his reg3 alpha is over 600, and now this gives him a MAP of 0.317 just from the difference in the reg3 alpha. That's an Ann Arbor 3, so you can see that this is a 0.317, and he's got greater than 0.29, so he's at high risk for a severe acute GVHD and NRM. That puts him on the red line here with less than 50% chance of responding to steroids. So he would need more aggressive immunosuppression at the very beginning. And here at Mount Sinai, we actually had a phase 2 trial of the monoclonal antibody natalizumab, which is an anti-alpha-4 receptor monoclonal in addition to steroids. So just to show you that that's the snapshot at the onset of GVHD. After GVHD, 1 week after treatment, you can use the same biomarkers. It's actually the very same algorithm. And here you see in data that we published a couple of years ago that in the black line, which is the early clinical response to treatment, that gives an AUC of only 0.65. The Minnesota risk at onset, so high risk versus low risk, that only gives you a 0.65. Sorry, the early clinical response was 0.68. The Minnesota risk was 0.65, but the biomarker AUC is 0.82. And what you see at the diamond, that's the threshold for the high risk. that has a sensitivity of 74% and a specificity of 83%. So as we published, this group overall has a non-relapse mortality of about 35% and an overall survival of 60%. But when you break that down into using the threshold of 0.291, you'll see that the majority of patients, 72% of the patients, are actually low risk and have less than a 20% non-relapse mortality incidence. Whereas the high-risk patients, that's less than 30%, but they have an almost 80% NRM incidence, and you can see the overall survival curves here. So in fact, these non-responders at 1 week of treatment, they're actually not non-responders, they're slow responders. They just haven't responded yet, and the biomarkers tell you that they have not had that much damage to their GI crypts, whereas the high-risk group definitely has had a lot of damage to their crypts. So those non-responders are true non-responders, and they need very intensive therapy if they're going to be rescued. Okay, so this is our patient. We'll imagine that he had high-risk markers at the start, and that he went on to the natalizumab trial that I just showed you. And so, but when he comes back 8 days later, he's still got his rash. He's not had any change in his diarrhea, and his bilirubin has actually moved up a teeny bit, but not enough to make him a liver stage 1. So technically speaking, he is a non-responder clinically because there's been no movement of his clinical manifestations. But when we send the biomarkers, what we find is that the ST2 is still in the mid-range, but his reg3 alpha has come down significantly to 164 nanograms per ml. That gives him a p-hat of 0.229, so he's low risk after treatment. And so this is what you would see if you sent these results to Viracor. This is the acute GVHD post-treatment algorithm, 0.229, and less than 0.291, low risk of severe GVHD. And here you have the individual biomarkers listed for you again. And so he's on the blue line with low NRM and good 80% overall survival. So the recommendation for this patient would be to continue the natalizumab and steroids. So to finish, let me just show you what we've done now in looking at the same group of patients over time. And we've published these data now at the end of last year. And we found that the map more accurately predicts non-relapse mortality than the clinical response at all time points. So we looked at 1 week after treatment, at 2 weeks after treatment, and 4 weeks after treatment. And what you can see is that the clinical response goes from 0.59 up to 0.7. Now you'll remember that the clinical response at 4 weeks is the gold standard for most GVHD treatment trials. But in fact, this is not a very good area under the curve. This is a good test, but it's not a great test. Up until now, it's been the only test that we had. But by contrast, the biomarkers at week 1 have an area under the curve of 0.81 that increased to 0.86 after 4 weeks of treatment. So this is really an excellent test that's giving you much more accurate sensitivity and specificity. If you try to combine, so if you look at the map at week 1, you actually get significantly more information than you would get at the clinical response at week 4. So it's better information earlier, which of course is very important for guiding treatment. And by the way, if you try to combine the biomarkers and the clinical responses to see whether you can improve on the biomarkers alone, in fact, you don't. You get a slight, it's not significant, but you actually get a slightly less accurate test because you are forcing a weak biomarker, which is the clinical response, together with a strong biomarker, which are the biomarkers, the maps, and what you get is a slightly weaker, strong biomarker. So if you had one piece of information 1 week after treatment for GVHD, it would in fact be the map. And changes over time are also important. And we can now see that at all time points, we've got more accurate information. And you can then use that to help guide treatment for your patients. So let me just end with acknowledging the people who have been so important in this work. John Levine, who is my co-director of MAGIC here at Mount Sinai. Umut Ozbek is our a statistician. Hannah Major-Monfried and Rishi Srinagesh were students who actually did the majority of the biomarker analyses for the map, both in steroid-resistant GVHD and their changes over time. And my colleague Dongcheng Zhao did the mouse work that I showed you in the beginning that helped us to understand the biology. So I'm going to stop there. And I thank you for your attention. And if we're in the live portion of the presentation, we'll now have a question and answer period.